So we've gone through all of the detail on the background, and now it's time for the fun. If an aneurysm is deemed appropriate for treatment, that is a ruptured aneurysm, a symptomatic aneurysm, or a large and or irregular aneurysm, we're going to talk a little bit about treatment. And so there are generally two treatment options, the famous clip versus coil debate, right? So there's microsurgery, which is done under a microscope, which is clipping, which is open brain surgery, is generally considered more durable than what I will call intrasaccular, not all endovascular approaches. I would say most honest hybrid neurosurgeons will tell you that microsurgery and flow diversion probably have comparable durability. So that old adage that microsurgery is more durable certainly holds weight for intrasaccular therapy, but not necessarily for flow diversion therapy, which we'll talk about. Microsurgery could be ideal if there's concern that there's an incorporated branch in the aneurysm. This can be a problem with a lot of MCA, or even rarely the anatomy of the Acomm can be a problem as well. And so these are things that generally push us towards thinking about microsurgery. Very rarely, but very complex aneurysms, blood, MCAs, or weird picas can need complex bypass procedures that can be done, which really speaks to the importance of maintaining complex fellowship training in open neurosurgery. Now, endovascular therapy has the quote advantage of having no craniotomy. It's not necessarily less invasive because the consequences can be just as bad as microsurgery, but it does allow for potentially faster recovery. And certainly, I think any honest hybrid neurosurgeon will tell you that if you can coil a ruptured aneurysm, that is the way to go. It is not fun to operate in a subarachnoid hemorrhage brain, no matter how seasoned you are. And so this is just a picture of microsurgical clips and a TCOM being coiled. So I do have to allude to two very important studies. That is the ISAT and the BRAT study. These are randomized studies that evaluated treatment of ruptured, not unruptured aneurysms. So ISAT, International Subarachnoid Trial, was a multi-center European prospective trial that looked at, over the time period, 22% of ruptured aneurysms that were deemed amenable to surgery or endovascular therapy. The majority of these were in good clinical grade in the anterior circulation because, again, they were something that they thought was safe for microsurgery. And the primary outcome was death or dependence at 1 year, and there were statistically significantly better outcomes with endovascular therapy. This was a post hoc analysis that showed better cognitive outcomes as well with endovascular therapy. And then there was a long-term study published a few years ago in The Lancet that looked at 10-year outcomes. And still, although survival and independence were not statistically significant, if you looked at survival or independence at 10 years, if you sort of put the two together, there was still a statistically significant benefit for endovascular therapy. There were more rebleeds in the endovascular group, although this difference was perhaps not clinically significant, as we still had better death or lower rates rather of death or dependence in the endovascular cohort. The Barrow Ruptured Aneurysm trial was a trial performed at the Barrow Neurological Institute over a decade ago. It was an intention-to-treat analysis of very well-matched cohort. So this was a different thing than ISAT, where they took aneurysms, they said, oh, these can be coiled or clipped. This was the BRAT study was an intention-to-treat analysis where everyone who hit the door, even angionegative subarachnoid hemorrhages, were randomized to either endovascular or microsurgical therapy. Now, this was a while ago. They used matrix coils that are no longer really used. But again, this was a true intention-to-treat analysis. And what they found in their 1-year study was a statistically significant lower rate of death or dependence in the endovascular therapy group. Now, when they looked at 10-year follow-up, this statistically significant difference did not bear out, although this was a subgroup of saccular aneurysms. I'm not sure everyone involved in the study really adjudicated this subgroup of saccular aneurysms, but nonetheless, the long-term follow-up was deemed similar, although I have this table exerted. The posterior circulation aneurysm still generally fared better with endovascular therapy, although the study is not powered enough to have statistical significance. I want to emphasize that very important point is that just because a p-value is greater than 0.05 doesn't mean there's no statistical significance. If a p-value is less than 0.05, even in a small study, that's a meaningful finding, that's real. But if a p-value is greater than 0.05, especially if the study is small, that doesn't mean there's no difference. I can't tell you how many papers I review where they look at 50 patients and they say, oh, there's no difference between these two modalities, but the study just isn't powered to detect a difference. But anyhow, I also think it's sort of a moot point. whether microsurgery or endovascular is better. I would say that if they're equivalent and one approach doesn't require a craniotomy, it's probably more reasonable to do the approach that doesn't require the craniotomy. If I'm going to go through a craniotomy, I'd want the approach to be statistically significantly superior than necessarily equipoise, but that's a whole different debate. So again, treatment options: microsurgery, endovascular. We'll talk a little bit about microsurgery, as most of my current practice does not at all involve microsurgery, although I certainly strongly feel that it is a strong role in the treatment of aneurysms still. So good clip candidates. So in general, unruptured aneurysms are much more favorable to treat microsurgically than ruptured aneurysms. Operating in a heavy subarachnoid hemorrhage fissure is not fun. It's more challenging. Certainly in the Acomm region, if you're trying to be honest and adjudicate whether you have issues with perforators after operating in a ruptured brain, it's a lot harder to preserve them, in my opinion. But again, unruptured aneurysms are also aneurysms where you really want to benefit. So if you partially coil a ruptured aneurysm and get it secured, get the patient through the subarachnoid hemorrhage window for a more definitive treatment down the road through flow diversion or clipping, that's probably very reasonable. But if you're taking an elective patient with an unruptured aneurysm and you don't get a complete or a reasonable result, what are you really accomplishing? So, durable treatment is really more meaningful in the unruptured setting. And also, again, surgery is a lot easier. Very small ruptured aneurysms can be very hard for endovascular therapy, so some of these certainly still need to be clipped. Very broad neck ruptured aneurysms as well. In general, favorable locations are the MCA and the PCOM. Aneurysms with mass effect as well, a PCOM with a third nerve palsy. They can do meta-analysis after meta-analysis, which they've done. It still shows better results for the third nerve if you do surgery. If you're concerned about follow-up as well, I think clipping is also a reasonable option. So again, clipping involves a craniotomy. This just shows what would be considered a traditional incision for a craniotomy. In this case, there was an orbitotomy performed as well for this aneurysm. And you can see that the surgery is done under the microscope. After the craniotomy, you split the sylvian fissure, which essentially refers to dividing the arachnoid that is tethering the opercular branches to either the frontal or the temporal lobe to create a safe plane to go down to the insula and then work your way down to the MCA. And then you put a clip on. Again, it's much more complicated than easy, but the experts make it look easy. But again, still an excellent modality that's needed for still a reasonable proportion of aneurysms for sure. So endovascular options, they're a lot more broad than just, quote, coiling. So you have intrasaccular options where you go into the aneurysm to deposit coils, and you may need a balloon to facilitate that, or a stent, or even just pop a web in. So to the far right, you can see there's a posteriorly projecting terminus aneurysm that's treated through web embolization. That's just a single device that you put in and deploy. And then we'll also talk about flow diversion, where you put a stent on the outside of the aneurysm, and the aneurysm gradually thromboses and occludes. Probably one of the most powerful and effective ways to treat an aneurysm if it's appropriate for flow diversion. So here are some examples of simple coiling. To the left, this is a basilar apex aneurysm that was ruptured, that was treated with coiling. This was a ruptured superior cerebellar artery aneurysm where we put a little coil in the daughter lobe at the top and then coil off the rest. And this is actually when I mentioned malignant pericallosal. So this was a patient who came in with a grade 2 subarachnoid hemorrhage all high up with this tiny pericallosal aneurysm that we just put one little coil in to secure. She was an elderly patient. And this just shows how malignant they are. And again, you could treat with simple coiling. What's nice is these small aneurysms tend to have smaller necks and are easier to deal with. Because if the neck is small, the neck is small, and small aneurysms, by definition, the diameter of the neck can't be too large. This is an example of a very broad neck pica aneurysm in an elderly patient that was treated with balloon coiling. You can see how broad the neck is there, and we used a balloon. And here's actually that ICA terminus aneurysm that was treated with balloon coiling. And so here's a nice illustration of stent coiling. This is an ophthalmic aneurysm. I did not elect to flow divert this because the artery had a tremendous amount of calcification in it. So you can see I start on the bottom left with a framing coil, but then you can see I put a second coil. There's significant coil herniation. And then as we move to the right, you can see how nice it looks, or better it looks after I put a stent. And then we completed the coiling. This is an example of a Y stent coiling for a basilar apex aneurysm. You can see there's actually two stents. You can see one limb of each stent into the PCA that then terminates into the basilar, and then you subsequently coil the aneurysm. This is something I don't do too much nowadays of this is a transcirculation stent where you put a stent from the PCA to the PCA by going through the PCOM. I don't do this much anymore because I'll use web for a lot of these. So what's happening on the far left is there's a stent that's deployed spanning the right PCA to the left PCA. There's a catheter that's traversing the left PCOM that deployed the stent, and there's a jailed catheter in the aneurysm that deploy coils, and you can see that we then coil the aneurysm to the result on the far right. Again, most of these nowadays are treated with a web, so this is a large basilar aneurysm where we just deploy a web device to manage it. Here's another one where there's actually incorporation of the left PCA into the aneurysm, where we just make sure we shelf a web up high enough to preserve flow into the left PCA. And here's a case of a basilar apex aneurysm. The reason I'm showing the CTA is the patient has very bad plaque, so this was done radially. I certainly believe I do a lot of interventions radially. I think it's a phenomenal modality. I don't think it's quite worthy of being put on Twitter every time I do it, but this is a case of a basilar apex aneurysm that we treated through a radial approach. And what's nice is you can sometimes mold the web. So in this case, I sort of molded the web to the shape of the aneurysm. You can see the follicle resulted in 1.5 years. This was a ruptured pica with a very broad neck. These can be very difficult to manage when they have a broad neck, certainly in the ruptured setting, and no one's excited about doing surgery. So this is very much off-label, but I used a web in this ruptured setting, and you can see the long-term follow-up result. I do think that web is still an intrasaccular approach, and it does have the limitation of coils intrasaccularly. I do see recanalization with web. It's certainly not as durable as clipping, but it does have its place as a relatively facile intrasaccular therapy in well-selected patients. So flow diversion, probably our strongest endovascular approach, and this is really the last thing I'll be talking about. You can see to the left, this is just a typical ophthalmic aneurysm treated with a flow diverting pipeline stent. The stent is shown here on the left. This is a larger bilobe basilar aneurysm that was treated with flow diversion and coiling to occlusion. And you can see this very irregular sort of moth-eaten communicating segment aneurysm treated with flow diversion as well. The results are often very satisfying in well-selected patients. Here's a distal ACA aneurysm. It's not really associated with the callosal marginal artery that was treated with flow diversion. And what you could see is that another effect of putting a stent in these beyond just diverting flow from the aneurysm is the flow diverter sort of relaxes the angle of the artery. Remember, these are hemodynamic. These aneurysms form due to curves or turns in the artery. So when you put a stent in and it relaxes that curve, that also has a bit of a therapeutic effect as well. And this was a good illustration of it. This is a cavernous aneurysm in a patient with a 6th nerve palsy that was treated with flow diversion. And this is sort of an off-label application. This is a very elderly patient with a ruptured anterior communicating artery aneurysm, really tiny, too small for me at least to manage with a coil. So I used a flow diverter that had good effect. And these are just some final cases where a mix of coiling and flow diversion. This is a partially thrombosed basilar aneurysm that I felt needed to be coiled as well, but I couldn't fit 2 catheters in through the posterior circulation, so I had to come transcirculation to put the coil catheter in, and then put a flow diverter and then coil the aneurysm. This is a vertebral basilar junction aneurysm, a significant mass effect on the pons that was treated by a combination of flow diversion and coiling. Again, flow diversion is really a powerful bullet that we have in endovascular therapy. This was that SCA case I showed early on. This patient actually presented not only with a 3rd nerve palsy, but with subarachnoid hemorrhage. There was a pseudoaneurysm associated with the aneurysm, so I put some coils in the pseudoaneurysm and then loosely packed the aneurysm. You can see the supracerebellar artery comes out of the aneurysm, so I don't want to close it off completely. So I used a combination of the coils, and I put a pipeline flow diverter in here. And you can see this is a 1-year follow-up. There's still some filling at the base of the aneurysm to preserve flow in the SCA, but for me, this is the best result I can get with this aneurysm.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.